Hello and welcome to this podcast on the primary survey. My name is Cosmo Skir and today we're going to be going through the primary survey and when you need to use this and how, if you need to use it, you do that. The most important thing about the primary survey is that you assess the patient, and this needs to be done as part of the survey itself, but also as deciding when the survey is appropriate. It is used in patients that you are worried about, and this can be seen in many different scenarios. For example, when working in accident and emergency, especially in the resuscitation areas, in any form of critical care, in the intensive care unit, or when working in pre-hospital care. It's also the basis for advanced life support courses and immediate life support courses and other courses run by the Resuscitation Council. And it's something which will come in very useful when working on call in any hospital. The first question you need to ask yourself is whether your patient or the person you're treating is sick. This is something that you learn in many areas of medicine, but again it involves looking around the bed and the scenario that the patient is in. And in pre-hospital care this would be the scene of an accident or situation, and in hospital it would be the bed area and the drains etc. around the patient. And you need to look at the patient themselves to assess from the end of the bed whether they are sick or whether they are not sick. And this will help you decide whether the primary survey is the appropriate way of managing the patient. If you look at the patient and they look like they're fairly well, and it's the sort of normal patient you see on the wards on a day-to-day basis, you may decide to make a full assessment in the usual way, taking a history and an examination, forming a differential diagnosis and making a plan, and this would be appropriate. It's for patients who are unwell that you may decide that the normal approach of history and examination is not appropriate. It's then critical, if you see someone who looks unwell, to find out if they're responsive. If they are unresponsive, then you need to move on to the usual approach. This involves calling for help and then basic life support or advanced life support as you are trained, and depending on the scenario you're in, you need to get, obviously, some help. But let's say that you have someone who is sick, who is unwell, that you've seen from the end of the bed or the situation they're in, and you're worried about them, and you don't believe them to be stable, or you have any suspicion that they are unstable and unwell, then you find out if they respond. If they do respond, this is when you can move on to the primary survey. This is what's often known as the ABC approach, and this makes it easy to remember and easy to carry out. And as you can see from this circle, it's something which is continuous. So the first step is airway, the next step is breathing. You then have circulation, disability, and then exposure. And as it says in the centre of the circle, it's critical that you assess each of these and correct them as much as you can before you move on to the next one. And once you've gone all the way around the circle, you then go back to airway. And if also at any point the patient deteriorates or the situation changes, you then go back to airway and start again at that point. You don't have to go all the way around the circle to exposure before you can go back to airway. The airway assessment is critical, and you need to find out at the moment whether it is safe and maintained. And there are many causes that you can read in the books or be taught on for unsafe airway, but the common ones are reduced GCS, so Glasgow Coma Score, from any cause. This can involve drugs, head injury, or it could be from foreign body obstruction, which is common, often from vomit or the patient's own secretions. And the third one, which is common, is airway swelling, which is often due to anaphylaxis. So if you believe the airway to be unsafe, then you need to do something before you move on to breathing. You don't just move straight on to breathing having assessed that it's unsafe. And on the right you can see it says airway at risk, support with following measures. The airway manoeuvres you can use you're taught in anaesthetics, and they involve a head tilt and a chin lift, but jaw thrusts can be used in patients where you think the cervical spine may be at risk. Airway adjuncts are used in patients where the airway manoeuvres themselves are not enough to help you hold the airway, or if the airway needs to be maintained for a long time, you may use a supraglottic airway device such as an LMA, and these are often used in theatre. Definitive airways are the best way of supporting the airway, but are only used in patients who need such an invasive way of supporting the airway, and in people who are trained to do so. So from all of these ways you can see a multitude of techniques for supporting airways in people you believe have unsafe or dangerous airways. And there are other things you can do, such as suction or putting a patient on their side if you believe secretions and blood are another cause of the airway obstruction. And as it says, once you're happy with the airway, either because the patient has kept it safe themselves or because you have secured it on your own or with help, you move on to breathing. Breathing, in any patient you are worried about, you initiate treatment with oxygen. This is the standard approach in immediate life support and advanced life support before you examine the chest, before you get saturation readings. So you give them high flow oxygen with a reservoir mask at 15 litres of oxygen and allow them to breathe away on that. Now it's important that the patient is breathing for something like a reservoir mask to be effective, so you need to quickly assess, are they making a respiratory effort? If they are making a respiratory effort, is the chest normal? And what is the respiratory rate? Is it fast or is it slow or is it normal? Obviously, if the patient is not breathing, they will not be responsive, and they would have been on the other end of our algorithm where we would have gone into basic and advanced life support, and the primary survey would not have been what we're doing. We would have been doing resuscitation. So in these patients, you need to have given them high flow oxygen, to have assessed their breathing, and then as your training allows, you may examine them further in terms of auscultation, palpation and percussion, and then you do other things such as measuring saturations, and if you have enough people to help you, you may do an arterial blood gas sample for assessing their breathing. In patients who are not breathing at all, or who are finding it hard to ventilate despite the fact that their oxygen is low, you may decide that they need help with ventilation, and these patients can be assisted using a bag valve mask with oxygen, and it may not be appropriate to just use a reservoir mask. These patients can also be assisted with things such as CPAP and BiPAP, and you want to be treating the underlying cause as well as you move on to circulation. On circulation, it's important that you examine the patient as with the other parts. And again, these are the things which you can see. A patient with cool peripheries, poor capillary refill, a low blood pressure, a high heart rate or abnormal heart rhythm may be someone who needs help with their circulation. And looking at the observation charts and ECGs and the other things such as urine output may give you an indication that the circulation is not functioning well in the patient that you believe is sick. These patients all need good IV access with large cannulae. Relevant blood tests can be taken at this point if extra cannulae are being inserted, and then the patient needs to be resuscitated at first with fluids, and crystalloids are as good as colloids in terms of the evidence base, so they're resuscitated with fluids. And in some patients you may feel that blood is appropriate if it is bleeding, which is thought to be the cause of the poor circulation. Another good way for monitoring circulation is to catheterize patients who need it. Disability is the next section, which is moved on to after circulation, and the critical things for measuring are the pupil size, which can give you a clue as to what's going on within the brain or any drugs that the patient has taken, the patient's temperature, giving them an idea of the exposure they've had and whether they're hyper or hypothermic, and their degree of consciousness, either measured using the Glasgow Coma score or using the AVPU score. And on the AVPU score, it works by saying whether the patient is either spontaneously alert, whether they're only responding to voice, whether they're responding to pain but not to voice, or whether they're completely unresponsive. The final stage on the primary survey is to look at exposure, and exposing the patient allows you to fully examine them and get clues as to why this person has become so sick. Looking for things such as rashes or swellings and injuries that weren't apparently obvious without exposing the patient can be useful. Also looking at recent operation sites where the patient may be bleeding, examining their abdomen, looking for hernias which can cause a patient to become septic and unwell and can often be missed, and looking for signs of either internal or external hemorrhage. Another important clue would be swollen limbs, which can be caused by deep venous thrombosis, which may lead to pulmonary embolus and an acutely unwell patient. So we've moved around the circle of the primary survey, looking at the airway, the breathing, the circulation, the disability and the exposure. And the critical thing to take from that is to assess the patient quickly, but to correct each step as you move on, so that you're making the patient safe and treating the most lethal things first, and keeping the patient alive until further help can arrive. So in summary, the first thing to do is to ascertain whether the patient is well or unwell, and therefore whether you need to be using the primary survey or whether you should just be taking a history and examining the patient in the normal manner. The next thing is to make sure you get help with these patients who are unwell. If you're having to do the A, B, C, D, E approach and you're having to correct any of these things, you probably should be getting assistance of other staff to help you with the patient. And the reminder to make sure that you're treating each step of this as you move forward and not just assessing and finding problems with each stage. Because if you leave a problem with the airway as you move on and assess someone's breathing and circulation and their capillary refill, you may well find that they're not breathing when you come back to assess them again. And the final reminder that if the situation changes or the patient deteriorates, you go back to airway and start from there, and then make sure you get help.